So if interstitial lung disease is suspected, evaluations should include, as I said, the chest X-ray quickly, and then a high-resolution computed tomography, so CT scan. In our institution, we do consult with a pulmonologist. They have to be involved. Oftentimes, I mean, they may consider a bronchoscopy because they want to rule out, infectious causes or other, like in our area in the Southwest, you have a high preponderance of valley fever, which can present insidiously, similar to ILD. So you want to rule out these reversible causes. There's typically testing of pulmonary function tests. Oxygen saturation is something we consider as the fifth vital signs. And then there may be other tests that could be considered depending on, the picture, like I said, infectious disease tests, bronchoscopies, and others, as decided by the multidisciplinary team. So it's key to get the proper testing early and to consult with the pulmonologist early on as well, to ensure that you're doing the proper workup for the patient. And as to continue to emphasize on the point that if you suspect ILD, then interruption of trastuzumab deruxtecan or any drug for that purpose that can cause ILD needs to be immediate. And depending on the symptoms, prompt intervention with steroids, with glucocorticoids, when appropriate, especially if the patient is requiring oxygen or there's evidence of significant inflammation, so pneumonitis with that. This may help reduce the severity of the complication and may frankly even cut down on the risk of developing further damage to the lungs. So this is important to keep in mind when treating those patients with interstitial lung disease, that you may prevent further damage, especially with more severe disease, if you intervene early with steroids as you're getting your consultations and your tests, etc., in place. For any of these agents that cause interstitial lung disease, and specifically these antibody drug conjugates, we have to keep in mind about half of the patients will not see any improvement, so this will be the new baseline. There's a small percent of patients that unfortunately dies, but hopefully with catching this early and intervening early, we won't see any further death from this complication. The other half actually will improve. Some of them actually will have complete resolution of their symptoms. Now, the question is about the timing. A lot of these improvements will happen over weeks, sometimes a couple of months or more to start seeing some improvement and resolution. So it takes a while. It doesn't happen overnight. It doesn't happen immediately as you stop the drug. So this is a process that will take weeks before it improves. Like I said, for 50% of the patients, fortunately, this will not improve. But thankfully, it will not get worse if you stop the insulting agent. Since the management is actually related to the drug injury and the lungs, which is not any different across malignancies, so it's specific to the agent, you stop the agent, and to the lungs, essentially, you do all that list I went through, including the institution of glucocorticoids as needed and oxygen. So this is really not very different across malignancies. Now, the severity may be different across different malignancies. For example, again, I think about our lung cancer colleagues where, this could be much, much worse because of, because of the baseline lung disease and the cancer involving the lungs. But I also think about, say, my patient with rectal cancer who has significant involvement of the lungs, then, this could be worse. And early institution of oxygen and steroids may be needed. I'll have a faster trigger finger of initiating steroids, say, on those patients than someone who has very clear lungs. Patients with cancer of the esophagus, squamous cancer of the esophagus, those patients typically are heavy smokers, heavy alcoholic. They have significant pulmonary disease. They don't typically have HER2 positive disease, but I'm using this as an example. Let's say, you end up with a rare patient with HER2 positive squamous cancer of the esophagus, or even some of the adenocarcinomas. Some of these patients also are heavy smokers, so they have some lung damage to start with. I mean, those patients will be treated a little bit more aggressively, at least, initially more aggressively than those patients, say, with colon cancer, very clear lungs with no lung involvement. So again, you have to individualize. It's very difficult to give a cookie cutter, answer for this, since it varies from patient to patient and from comorbidities. The cancer itself does not determine what you do. It's the it is the comorbidities that come with the cancer and the drug and the insult and injury that determine the level of response.